Continuum distortion, one of the 6 principal distortions in the fascial distortion model, F.D.M, which addresses disruptions at the transition zone between bone and fascia. What is continuum distortion? A continuum distortion, CD, occurs at the transition zone between bone and fascia, where the soft tissue gradually becomes mineralized, forming bone. The key idea here is that the human body is not made of separate parts like bones, ligaments, or tendons, but rather it is all part of a continuum, a seamless structure. Dr. Stephen Topaldos, who introduced the F.D.M, emphasized this concept by explaining that fascia doesn't stop at certain points but continues, adapting into different forms across the body. In the fascial distortion model, bones aren't seen as separate entities like the femur or radius. Instead, these are just regional identifiers. The transition zones where fascia merges into bone, which we call tendons or ligaments, are particularly vulnerable to stress and injury. These zones are highly dynamic, capable of shifting between flexible and rigid states depending on the demands placed on them. Continuum distortions occur when the transition zone loses its ability to adapt and shift between these flexible and rigid states. Normally, calcium flows into or out of the transition zone, strengthening or softening the connection based on the forces it encounters. When this process is disrupted, such as through trauma or repetitive strain, the transition zone can get stuck in one configuration, leading to pain and dysfunction. Let's break this down with an example. Imagine a sprained ankle. The transition zone between the calcaneus and ligaments is exposed to unidirectional and multidirectional forces simultaneously. If one part of the transition zone is pulled into a rigid mineralized state, while another part is stuck in a flexible soft tissue state, this imbalance creates a continuum distortion. This makes the transition zone incapable of handling normal forces, leading to the sensation of pain. Types of continuum distortions. There are 2 primary types of continuum distortions: Inverted Continuum Distortion, ICD, and Everted Continuum Distortion, ECD. Let's take a closer look at both. Everted Continuum Distortion, ECD. In an everted continuum distortion, the transition zone is stuck in an osseous, bone-like state, with calcium getting stuck in the fascia-bone interface. The patient often identifies the pain as a tender calcific spot on the periosteum, the outer layer of the bone. The distortion can be palpated as a small, hard lump, almost like a grain of sand beneath the skin. Inverted Continuum Distortion, ICD. On the other hand, an inverted continuum distortion happens when the transition zone is stuck in a ligamental, soft tissue state, meaning the mineralized parts aren't integrating properly into the bone. This type of distortion feels like a devet or a small indentation in the bone. Patients often describe it as deep pain, similar to a hole in a belt analogy, where the tissue is weak or sunken. Diagnosis of continuum distortion. Diagnosing continuum distortions can be tricky, as they often don't show up on X-rays or MRIs. Instead, we rely on the patient's body language and feedback. Treatment of continuum distortions in the fascial distortion model. The treatment of continuum distortions within the fascial distortion model is a manual therapy technique designed to correct disruptions at the fascia-bone interface. Continuum distortion can occur in 2 forms: Everted Continuum Distortion, ECD, and Inverted Continuum Distortion, ICD. Each form requires specific approaches to restore the normal physiological balance of the transition zone between bone and fascia. Treatment of Everted Continuum Distortion, ECD. In everted CD, excess osseous components are pulled into the fascia, causing a painful calcific sensation. The goal of treatment is to push these components back into the bone, allowing the transition zone to return to its neutral state. One, palpation. The practitioner uses their thumb to locate the tender spot of the everted distortion, described as a small, rough area often about the size of a lentil. 2. Pressure application. The thumb is applied with firm, direct pressure to the identified spot. The force should be constant and sufficient to recreate the patient's pain, indicating correct placement. 3. Release. The treatment force is held for 5 seconds to 30 seconds, or until a sudden shift is felt. This release is often described as a sensation similar to a button slipping into a buttonhole. 4. Outcome. Once the osseous components shift back into the bone, the patient's discomfort dramatically decreases, and the neighboring joint shows improved strength and mobility. Treatment of inverted continuum distortion. Treatment of inverted continuum distortion, ICD. In inverted CD, the transition zone is stuck in a more flexible ligamentous state, and calcium cannot shift into the zone from the bone. ICD is more challenging to treat than ECD because it requires pulling osseous material out of the bone. Palpation and pressure. The practitioner applies the same thumb pressure technique, but rather than pushing, the goal is to manipulate the unstuck portion of the transition zone. This often forces the stuck portion to follow and return to its neutral state. Adjunct techniques. In cases where direct pressure does not resolve the ICD, thrust manipulation of the nearby joint can help by pulling calcium into the transition zone. This technique is commonly used for ICDs in the sacroiliac joint and spine. Reassessment. ICDs may reoccur within hours or days, requiring repeat treatment. If manipulation is effective, the transition zone shifts fully back into the bone, and the distortion is corrected.
Pressure is fine.
Principles of treatment. All or none. Continuum treatment works on an all or none basis. Either the transition zone shifts completely, or no improvement is observed. There is no partial resolution. Direction and force. The practitioner must ensure that the pressure is applied in the correct direction and with adequate intensity. The force should replicate the intensity of the injury to trigger the release. Follow-up. After successful treatment, reevaluate the patient's range of motion and pain levels. In some cases, additional CDs may be present, requiring further treatment. In conclusion, the treatment of continuum distortions involves the precise application of manual pressure to restore the balance between fascia and bone. Whether addressing everted or inverted CDs, the goal is always to restore normal movement and reduce pain by correcting the stuck transition zone. Continuum distortions. Body language. Pointing with a single finger to a bony spot. Verbal descriptors. Patient will identify a single discrete point of pain. Objective finding. Restricted ROM in one plane. Treatment. Reduction of shifted continuum material by application of pressure from the tip of the practitioner's thumb. Pay attention to the angle of the patient's finger when they are showing where the CD is. This angle is often the angle needed for reduction of the CD.